Assalamu alaikum. So our today's topic is Mooren corneal ulcer. First of all, see its definition that it is a chronic, painful peripheral corneal ulcer. As its name indicates that it is peripheral corneal ulcer, it means it occurs at the periphery of the cornea. We can also say that it occurs near the limbus. Limbus is the structure between the cornea. We can say that it is junction at the cornea and sclera, and it is very painful condition. Patient has severe intolerable pain in this condition. I would like to mention here that this Mooren ulcer is also known as idiopathic keratitis. Why it is known as idiopathic? Because its exact cause is unknown, and the etiology which is mentioned in your book is just based upon the suggested causes or suggested logics. It is also known as chronic serpiginous or corneal rodent ulcer. Serpiginous, Serpiginous. Okay. So why it is called so? It is called so because of its shape. You can see here that it resembles just like a serpent. Okay. And why it is known as rodent also? You know that rodents are rats. Some we can say that animals like rats, they are rodents. And why this corneal ulcer is known as rodent ulcer? Because here furrows are formed. Furrows are actually small thin parallel channels like this is a channel that is formed in the cornea, and as these channels or thin parallel channels are formed by rodents or rats in the soil, so this just resembles to the etiology, or we can say that pathogenesis of the Mooren corneal ulcer, so we have named it so. You can see from this diagram that this is a furrow, small narrow channel made in the soil in order to provide water to the crops, or we can say that for the irrigation of the crops. But it is superficial ulcer. Okay, so here shallow furrow is formed, not so much deep furrow like rats form so much deep furrows in the soil. Okay, but it is shallow furrow, not so much deep, because all the corneal layers are not involved here in this case. Okay, so it is also a very rare condition, and it is a superficial ulcer, and in this case only the epithelium and woman's layer and superficial stroma is involved only in this case. Okay, you know that this is your epithelium and this is your woman's layer and this is the stroma. Okay, whenever all these things or all these layers are damaged, there is a defect produced in the cornea. Okay, there is a defect produced in the cornea, so it is known as ulcer. As I explained it before, that it ulcer is an excavated defect that is produced on the surface of any area or as a result of after effects of any inflammatory process. Okay, so this type of ulcer basically starts as small patches of gray infiltrates at the periphery of the cornea, and then they coalesce to form a shallow furrow. Okay, so now let's look at the book, that what your book says about it. Its etiology, first of all we will talk about its etiology. It is an autoimmune disease. Autoimmune disease is any disease in which your body's immune system becomes active against your body's own cells, like in this case corneal cells. It is an autoimmune disease which causes vasculitis of limbal vessels. Why not corneal vessels? Because cornea is a vascularized structure, so cornea is not involved here, rather there is vascularitis of limbal vessels, and it results in ischemic necrosis that produces enzymes like collagenase, proteoglycanase, and it results in the causation of ulcer. Your cornea is basically made up of collagen. 90% content of your cornea is collagen. So if there is collagenase enzyme, then all that collagen in your cornea will start destroying. Like here is, it is full with collagen. If collagenase enzyme comes, your collagen of cornea destroys, and ultimately your cornea is destroyed. Now let's talk about its types. It has two types. One is limited form and the other one is progressive form. In limited form, It is a unilateral condition. It is benign. You know what is benign? Any we can say the defect that remains localized to any particular site and it don't invade to other sites is known as benign, and it occurs in older patients. In progressive form, it is often bilateral condition, and it is also relatively progressive, or we can say relentless progression occurs over here. So we can say that it is a malignant condition and it occurs in young patients. It can be a malignant condition, not exactly malignant. What are the clinical features? Symptoms are the features that are told to you by your patient: severe intolerable pain, lacrimation, photophobia, red eye, and decreased vision. Why decreased vision? As you know that cornea is a transparent structure and the light passes through your cornea and image is produced, and if there is any defect in the cornea then it would not happen, and ultimately patient presents with decreased vision or loss of vision in progressive or advanced cases. Signs are the features that are seen by doctor in the patient. Whenever a patient comes to you, you will see excavating ulceration at the periphery of the cornea. I explained before, there is destruction of corneal epithelium and superficial corneal stroma. And this ulcer basically has a raised border, you can say here, and it also has it also has overlying or overhanging mainly central ridge. Okay, like this is overhanging central ridge at the advancing edge, and at the base of the ulcer there is thin vascularized cornea, and this type of ulcer progresses first circumferentially and then centripetally or axially, and finally involves the whole cornea in some cases, but in other cases it doesn't involve the whole cornea and the remaining cornea remains clear and transparent. Okay, so scleral involvement, like this is your eye. Okay, this is sclera. Scleral involvement is very rare in this condition, but in progressive form of the disease scleral involvement is very high. Okay, so perforation is also occur in this condition. Now come to the treatment. What is the treatment? First of all, a patient comes to you with Mooren ulcer. What would you do? You will give topical therapy, which is steroids. Steroids are given because they play a role as immunosuppressive. So they are given after every hour initially, and then when the condition improves, then the frequency of the dosage is reduced. Cyclosporine is also immunosuppressive. Interferon alpha 2 can also be given. Cycloplegics like atropine is given for the relief of the pain. Why pain occurs and why atropine is used for the relief of the pain, I have explained it in my previous video in bacterial corneal ulcer. In the treatment of bacterial corneal ulcer, I will not explain it here because it is a long discussion. Then comes antibiotics. Antibiotics are must given because they are given to prevent any secondary infection. Then there is systemic therapy. This therapy is given in which systemic immunosuppressive drugs like systemic steroids, cyclosporine, and other cytotoxic drugs are given. As you know that collagenase was the major enzyme here which was producing the destruction in the cornea. So if we give collagenase inhibitors like tetracycline or doxycycline, this condition can be prevented. But is it a permanent treatment? If you give steroids, immunosuppressive drugs, then the condition is completely relieved? No. What would happen to the already damaged cornea? In order to cure the already damaged cornea, we will do conjunctival resection. In this case, like this is your cornea. In this case, peripheral 5 to 7 mm or 4 to 7 mm of conjunctiva is excised. Like this is conjunctiva. Mainly this is cornea. This white portion is sclera, and over this white portion there is a transparent layer which is known as conjunctiva. Here conjunctiva was acting as a source of collagenase, proteoglycanase, and other inflammatory mediator. So we do conjunctival resection here. So all these things are not provided, or all these enzymes are not provided, and the condition will not prevail. Okay, keratoplasty can also be done. It is given or it is done in very much resistant cases. Why? Because as it is a sort of corneal graft or graft from another person, So graft rejection chances are very much, or graft melting would occur in this case due to host immune response. Okay, so it is done only in resistant and exceptionally painful cases. What are the DDs or differential diagnosis? As it can be asked in your exam or viva question, but it is not mentioned in your book, so you must add them up here if you want to do so. First differential diagnosis is collagen vascular disease, in which there is peripheral arteritis nodosa, SLE, and rheumatoid arthritis. Other one is corneal degeneration like terine or pellucid degeneration. Others are staphylococcal marginal keratitis or ocular rosacea. Now, look at this diagram. As I said before, that initially it is at the periphery of the cornea. Okay, and then it progresses first circumferentially and then centrally, and it try to involve your whole cornea in some cases, and in other cases it doesn't involve your whole cornea. Okay, so that was all. Thank you very much. Allah Hafiz.